Kiran sir, can we start the recording? Good afternoon, everyone. iTech India welcomes all the participants for today's National Distance Learning Seminar Series. We are disseminating the national guidelines for HIV care and treatment 2021. Today's topic is Introduction to Opportunistic Infections, Central Nervous System. And the speakers are Dr. Chinmoyee Das ma'am from NACO, Dr. S. Anuradha ma'am from COE MAMC, and Dr. Amit Harshana sir from iTech India. We welcome you all. Participants are requested to please put their questions in the chat box, or we can take them at the end of the session. I now request Chinmoyee ma'am for the opening remarks, please.
Thank you, Shweta. Am I audible?
Yes, ma'am.
Thank you. So at the outset, I'd like to wish you all a very good afternoon and welcome Dr. Anuradha and Dr. Amit and everyone, all the experts and all the officers from SACS and also all the staff of ART centers. This is a very important session because when we talk about opportunistic infections, we have to deal with a lot of challenges in diagnosing them, a lot of challenges in treating them. When a person with HIV is having an infection by another microbiological agent, there are many aspects which you have to look at. Be it the signs, symptoms, identifying them correctly, sending them to the right place for diagnosis. By right place, I mean they should know which are the laboratories for diagnosis. You have to know which are the laboratories which test for these specific diseases, because not all labs have all equipments to test for all the OIs. So if it is a complex opportunistic infection, so you have to really know where to refer the patient, which is very important. So having said this, I mean, I'm sure you have gone through the classification of the opportunistic infections. So the most important of them, and since we are going system-wise, so today we are going to deal with the central nervous system. So here, the signs and symptoms of different OIs which are presenting as neurological manifestations. What you have to know is how to identify these neurological symptoms so that you don't miss them. That is very important. So to understand the operational flow for screening these patients, when not missing out any important step in screening is very crucial. And then next, coming to management, you have to understand that there could be drug-drug interactions. There could be some other infection which is masking certain disease that also has to be taken care of. And along with ART, what you can give, how much you give, whether you have to give empirical treatment for some suspected disease. So all that has to be clearly and very lucidly understood. And I'm sure Dr. Anuradha is a wonderful teacher, and she really clarifies many things on this aspect. And we hope that she'll take us through the opportunistic infections of the central nervous system. And I wish all the ART staff understand all these concepts, and please clear all your doubts today, so that when you go back and you will see any case with any neurological symptom, you don't miss out on referring the patient to a particular center or managing the patient, whatever the case may be. So thank you. Over to you, Anuradha ma'am.
Thank you, ma'am. We'll just quickly run through the pre-test. Kiran sir, can we have the pre-test, please? The pre-test is now visible on your screens. There are 4 questions in all. Please scroll through the questions and answer all the 4 questions. Kindly note that the pre-test and the post-test are related to your attendance. So please attend the session till the end and attempt the post-test as well. We have another 2 minutes for the pretest. Participants are requested to please attempt the questions. Kiran sir, we can end the e-poll now. Thank you. I now request Dr. Amit sir to please continue the session.
Thank you, Shweta, and good afternoon, everyone. And thank you, Dr. Chinmoyee, for setting the context and giving the recommendations and suggestions. Shweta, I can still see the polling.
So please just cancel it from your screen, sir. If you can click on that cross.
Sure. Okay.
Yeah.
Thank you. So next slide, please. Again, for the introduction's sake, because we are starting the section 4, which is about opportunistic infections. So on the left side on the screen, what you're seeing is the guidelines which were there, and it was written in 2007. So now, almost a decade, and even more than a decade now, these guidelines are being revised. On the left side, below, what you're seeing is the number of chapters that are there in the opportunistic infections section. So you have introduction, central nervous system, respiratory system, gastrointestinal system, and skin and mucous membrane. And today we'll be dealing with the 4.1 and 4.2, and subsequently all the different chapters would be covered in the subsequent NDLS sessions. Next slide, please. So as I said, today's session content, we'll be covering chapter number 4.1, which is about introduction to opportunistic infection. So I'll give a brief on that. So it is only going to be a few introductory slides. And then Dr. Anuradha ma'am would take us through the central nervous system, covering all the different opportunistic infections of the system. Next slide, please. Next. So giving the introductory remarks, I mean, to start with the definition of opportunistic infections, and I'm sure all of you must have seen this thousands of times. So the opportunistic infection is a disease caused by a microbial agent in a person with a compromised host immune system. So that's important to know and note that, we are talking about the compromised host immune system when it is opportunistic infection. Similarly, if you relate with co-infections, so PLHIV can also have, let's say, for example, hepatitis, which is coined as co-infection, versus when you have the disease because of the compromised immune system that is known as opportunistic infection. And the acquired immunodeficiency syndrome, or AIDS, is defined as the occurrence of life-threatening of these opportunistic infections, malignancies, some of the neurological diseases, and other specific illnesses in patients with HIV infection, and specifically with CD4 count of less than 200 cells per cubic millimeter. Next slide, please. So talking about the background, I think we all are very much aware that when we talk about the morbidity and mortality among PLHIV, it is not majorly, or let's say HIV per se, it is majorly because of the opportunistic infections involved, and that's the major reason for all the morbidity and mortality. So it is very important, as Dr. Chinmoyee already mentioned, that the early diagnosis of these opportunistic infection, screening of the opportunistic infections in the ERT center, and usage of chemotherapy and prophylaxis to prevent the various opportunistic infections. And also, it is important to note here that what we have seen over the period of time, looking at the data, that the mortality pattern, which is almost getting plateaued, or there's a lot of push which is required to further reduce the trend of mortality. And I think for that, what is the most important thing is we have to diagnose the opportunistic infections quite early, along with doing all of the things. So I guess in the systems that we are going to cover now, in the guidelines, what you would also notice is that the combination of signs and symptoms have been given as prompts or boxes for us to diagnose and see, or think about, like, which could be this particular OI, so that we can diagnose it early and do the benefit for the PLHIV. And also there was a big systematic review which was done in covering almost three big regions, covering South Asia, covering Sub-Saharan Africa, Latin America, wherein almost like 126 studies were reviewed for almost, with a span period of 20 years. And what it showed was, which is also known for all of us, that ART led to greatest reduction in the incidence of all opportunistic infections, specifically during the first 12 months of ART usage, ranging from somewhere around 60 to 90%, except for TB, and that too for unspecified TB, because it takes some more time, more than 1 year. And the largest reduction was also seen for oral candidiasis, PCP, and toxoplasmosis. So all in all, what we are saying is, like, we have ART in place, we have prophylaxis measures in place. So we have also already covered the prevention of OIs chapter before. Now it is very important for us to focus on how we can diagnose the OIs early, so that we can either provide prophylaxis or do the management of that particular OI if OI is not there. And also one more important thing here, which I missed talking about, is when you see the screening for OI in persons at risk, particularly before starting ART, will reduce the incidence of iris. So this is something which we have come across, and a lot of questions that the field people are asking, like, is it okay to start ART? Is it okay to do the ART initiation rapidly, or like, as soon as possible? So I think what is very important here is that if you look at the rapid ART initiation algorithm provided by NACO, and which is there in the guidelines, that if you exclude all the danger signs, and if you actually meticulously and religiously do that, so the negative predictive value of that particular exclusion is so high that there is very little chance for you to have the iris coming, within few weeks when you start ART. So that's very important. So if you religiously and meticulously exclude all these danger signs and then start an ART, so probably that will reduce the incidence of iris as well, which has been the major hindrance for a lot of people thinking about that. We should start the ART as soon as possible or not. Next slide, please. So the incidence of opportunistic infection, it majorly depends on the immune status of the patient. So when we talk about the CD4 cell counts and the endemic prevalence of the causative agent. So we'll also see in the subsequent sessions. So for what is the virulence factor, what are some of the specific agent-related factors, meaning some of the geography-related status, etc., which are related for the incidence of opportunistic infections. Next slide, please. So if you look at this slide, I think thousands of times, again, all of you must have seen this. But if you follow the trend of CD4 counts, it goes to the lower nadir level and then rebounds back. And then it's a natural course of the disease, wherein you would find that somewhere around 50 to 100 cells per year, CD4 cell counts reduction that you observe. So on the top, talking about talking about tuberculosis, which is seen across the CD4 counts, and bacterial pneumonia, zoster or diarrhea, which is also similarly seen in immunologically normal people. So those are the disease patterns that you would see with the CD4 count somewhere around 500. The moment the CD4 count reduces further, so somewhere around 200 to 400, you would start seeing some of the very specific opportunistic infections which are HIV associated. So oral candidiasis, molluscan contagious dermatitis or folliculitis. Similarly, further when it goes down below 200 or less than 100, let's say, specifically, so it is very important to also remember this, because in the ART center, you also have to have that correlation. So for example, somebody presenting with shortness of breath, and when you know that the CD4 count is less than 200, and we all know that, sometimes PCP presents with atypical pattern. So it is important to remember that somebody presenting with those symptoms and with CD4 count of less than 100, there is very much likelihood that the patient might have pneumocystis pneumonia. So similarly, those CD4 counts are related to less than 200 when we talk about pneumocystis pneumonia, cryptococcal meningitis, toxoplasmosis. All of these things we would be covering in the CNS chapter today. And specifically when we talk about CD4 count of less than 100, we typically see Mycobacterium avium complex or cytomegalovirus related retinitis or colitis, and PML you see, and microsporidiosis, cryptosporidium, and some of the primary CNS lymphoma. Next slide, please. So this in this slide, what you're seeing here is in the guidelines you would find that so this talks about the pooled estimate proportions of all opportunistic infections, meaning typically what you're expecting is so this is given as a one data point, but there is a definitely range involved. But for the ease of following it by the ART center staff, it is given as one standard point measure. So what you're seeing here is the maximum or the most prevalent opportunistic infection which is seen among PLHIV is tuberculosis, followed by oral candidiasis and diarrhea, and then herpes zoster, herpes simplex, and cryptococcal meningitis. And the list follows from there: PCP, Cmb retinitis. What we have tried doing, what NACO has followed is that the data on proportions of opportunistic infections was compared across the different geographical regions of the country, and then the pooled estimate was calculated. So this gives you a fair picture of what's going to be the typical pattern or the burden of opportunistic infections among PLHIV. Next slide, please. And similarly, this also is following the same pattern, and the pooled analysis has been done comparing the different geographical regions, because so India is such a big country and you get a lot of variations. So this is why it was taken care that there's enough representation of different geographies. What you're seeing here is the most common signs and symptoms that you are going to come across in your ART center is fever, weight loss, cough, shortness of breath, lymphadenopathy, diarrhea, and then the rest of the symptoms that you're seeing in the list. Next slide, please. So it is important to know, I think in the subsequent sessions, we'll be also dealing in details of this, that for strategies for diagnosis of opportunistic infections, we have to note and make sure that there is early identification, and also as early as possible, if the diagnostic modalities are present, we have to refer or do the necessary follow-ups. OI management in patients on ART, timing of initiation of ART in presence of an OI, which we would be seeing in each and every opportunistic infection when we talk about what's the timing of initiation of ART in relation to that particular opportunistic infection. There's some recommendations during pregnancy, some understanding of geographically distinctive opportunistic infections, that's also important. So for example, penicilliosis, which is also known as telleromycosis now, it's pretty common in northeastern part of India, and leishmaniasis, which is mainly endemic in Bihar and some parts of Calcutta, some parts of West Bengal, UP, and Jharkhand. So these are some of the things which we should always keep in mind when we're diagnosing opportunistic infections, and definitely the drug interactions during concomitant administration of treatment for opportunistic infections and ART. Next slide, please. So this is just a snapshot of what you're seeing in the guidelines. So according to the pathogens, there has been a division. So I'm not going to go through each and individual pathogen here, but this is for your reference, and you can always look at the guidelines. So for example, if you look at the fungal components now, Pneumocystis jirovecii pneumonia has been classified under fungus. There had been some discussions, but now it is classified under fungus. And similarly, telleromycosis. So this is Telleromyces marfani, which is causing telleromycosis or penicilliosis. So likewise, according to based on the pathogens, this has been divided according to the class. Next slide, please. So various opportunistic infections which would be covering, and so today Dr. Anuradha ma'am is going to talk about CNS system, but respiratory system, GI system, all the enlisting is there in the introduction page, because that's what is going to be followed in the subsequent chapters that you're going to read in the guidelines. Next slide, please. Next. So, and also we have tried to cover some of the common diagnostic and treatment related challenges. But again, when we talk about each and every individual opportunistic infection, at that time also we are going to go into the details of that. So just to give you the snapshot quickly, for tuberculosis, we all know that the bacillary TB forms of the atypical clinical presentation, specifically with the advanced HIV disease, when the CD4 count is less than 100 or even more with less than 50, when we know that the diagnosis is tough, and also the sensitivity of the NAT also decreases. So those are typical diagnostic, some of the challenges. It is also difficult to get a good clinical specimen from extrapulmonary site, especially in CLHIV for NAT testing. And the facilities for diagnosis of EPTB are not present across all the ERT centers, like ultrasound and ophthalmoscopy for ocular TB or for abdominal TB, for example. So for candidiasis, non-availability of the referral facilities like endoscopy. For PCP, usually it is a clinical diagnosis. Hence, there is an ongoing need to train the medical officers to enable them to suspect PCP. So giving them a package, and this is what we'll see in the subsequent chapters. Next slide, please. Cryptococcal meningitis, we are going to cover that today. So, the CSF sample collection, the issues with that, and also the differentiation between new and relapse cases, that has been a big issue. And also because, the culture testing is not available everywhere. Since we are starting with the treatment, later on, this is going to be a big issue for us because, the limitation of sometimes the culture testing in the remote settings. Toxoplasmosis, it's majorly a clinical diagnosis, which Dr. Anuradha ma'am is going to talk about today. Chronic diarrhea, some lack of sensitization across all the RT centers. So when we go into the gastrointestinal system in coming sessions, we'll also go deeper into how we diagnose and what do we do for chronic diarrhea. Cmb Retinitis, again, because the fundoscopy and ophthalmologist needed for the confirmation, so that becomes one of the limitation. Next slide, please. Cryptococcal meningitis, again, related to treatment because it has got a long duration of treatment and also the maintenance phase, which goes almost for a year. So that becomes one of the limitation. And the treatment options in relapse cases are limited because some of the antifungals, which are, if fluconazole is not working, then what are the options? And, these are quite expensive molecules. And the non-availability of certain drugs to manage opportunistic infections across the ERT center. So this has been, this is something which programmatically has to be improved so that we can do better for diagnosis and management of OI. Next slide, please. Thanks. So I would hand over to Dr. Anuradha ma'am from here for central nervous system. Thank you, Shweta.
Thank you, sir. I now request Anuradha ma'am. Yeah, thank you, ma'am.
Thank you, Dr. Amit, for that very kind introduction to opportunistic infections and for setting the tone for the next part of the session, which is on opportunistic infections, which are pertaining to the central nervous system. This is a rather very long session, and I will try to cover it as quickly as possible because there are too many slides and we have a lot of important OIs to cover as part of central nervous system. Next slide, please. So when we look at the central nervous system, HIV is a neurotropic virus, which means that it has a predilection to infect the nervous system. And the HIV virus enters into the nervous system very early on in the infection stage of infection, and it stays there. So HIV can affect the nervous system in two ways, either directly by causing neurotropic effects. That means whatever disease manifestations it produces are directly because of the viral pathogenic effects itself, or because of the action on CD4 cells and causing low CD4 count, like Dr. Amit was talking. It can predispose to multiple and numerous types of opportunistic infections, which involve the nervous system. So you can either directly involve the nervous system per se or through the opportunistic infections. And it is very important to remember that any level of the neuraxis can be involved from the brain to the meninges to the spinal cord, the nerve and the muscle. We tend to focus most of our attention to the brain and the meninges, but we must remember that myelopathy, neuropathy and myopathy, and at multiple levels also, HIV can involve the neuraxis. And it is important to note that neurological disease may actually be the first manifestation of symptomatic HIV infection in about 10 to 20% of people. And it is generally accepted that about 60% of patients with advanced HIV disease will have clinically evident neurological dysfunction during the course of their illness, which just tells you how important nervous system manifestations and nervous system involvement in people living with HIV/AIDS is. Next. So, like we said, the neurological manifestations can be classified or categorized into two types: those which are directly related to the HIV infection and those that are related to opportunistic infections of the nervous system. The HIV-related neurological manifestations of HIV infection are acute aseptic meningitis, various forms of chronic meningitis, HIV-associated neurocognitive disorders, also called HAND, which was earlier one of the types was known as HIV-associated dementia, Hiv encephalopathy, Bacular Myelopathy, which involves the cord, peripheral neuropathy, which involves the nervous system, and myopathy, which involves the muscles. So all these are neurological manifestations of HIV infection. And the numerous opportunistic infections which can affect the nervous system are Cryptococcal Meningitis, cerebral toxoplasmosis, Cmb Retinitis and encephalitis, in addition to a dissemination of the Cmb infection. Very important OI called progressive multifocal leukoencephalopathy, also called PMLE, primary CNS lymphoma, CNS tuberculosis, and CNS syphilis. Next. We can see both HIV associated manifestations as well as OIs related to HIV, and both of them are seen equally in people living with HIV. And if we look at the symptoms with which the patients present with neurological manifestations or neurological diseases, they can be grouped on the basis of a constellation of symptoms and signs into major syndromes. There can be a syndrome of meningitis, where patients will usually present with headache, fever, nausea, vomiting, altered sensorium, and on examination, you may get features of raised ICT as well as a positive meningeal signs like a Kernick sign or a Brudzinski sign or neck rigidity. And there are numerous causes for meningitis, most important of them being tuberculosis, the next important one being cryptococcosis. But syphilis and other bacterial infections can also present with meningitis. Then there is the syndrome of focal cerebral lesions, where the patients present with focal symptoms like headache, focal seizures or focal convulsions, and focal signs. Means there could be a monoplegia, there could be a hemiplegia, there could be an isolated cranial nerve involvement, meaning there is a focal loss of neurological function or there is a focal deficit. And the common causes for these are space-occupying lesions, for example, tuberculomas, toxoplasmosis, PML, syphilis, primary CNS lymphoma, neurocysticercosis, and many of them look very similar on an MRI also, and they will present with what are so-called ring-enhancing lesions. So there needs to be a very high degree of suspicion as to when to suspect which of these ring-enhancing lesions or lesions is responsible for the focal cerebral disease or focal cerebral lesion with which the patient has presented. Then patients can present with an encephalitic-like picture where there is cortical involvement, there is cognitive impairment, there can be psychiatric manifestations, patients can have altered sensorium, and patients will have seizures. So presence of seizures indicates encephalitis to a large extent. CMV, HSV, and toxoplasmosis are the important causes which present with an acute encephalitic kind of a picture. Then if there is involvement of the cord, then it produces a myelitis-like picture where there can be sensory disturbances, there can be a level of paraplegia, there can be sphincter disturbances in the form of urinary incontinence or urinary retention. And then you will think that the cord is involved in these patients. And in addition to HIV myelopathy, there can be cytomegalovirus, herpes, both simplex and virus myelopathies, syphilis, toxoplasma, and also tuberculosis can present as a myelopathy. Then patients who present predominantly with neurocognitive decline, that is, there is a deterioration in the functional status of the brain, meaning they have loss of memory, regression of milestones in children. They can present with loss of neurological functions, loss of executive functions like speech, memory, dexterity, and other fine functions, neurocognitive functions. There is memory loss, behavioral abnormalities. These patients are then classified specifically as HIV-associated neurocognitive disorder. So these are the key symptoms and combinations, and depending upon what is the clinical sign and symptoms with which the patient has presented, then you can possibly think of the underlying etiology and then of the possible organism which is giving rise to that particular syndromic presentation of opportunistic infections in neurological disease. Next. So let us start with one of the most important neurological manifestations or opportunistic infections which is seen in patients with HIV infection, and that is cryptococcal meningitis. We are not dealing with tubercular meningitis here in this session at all, because TB gets covered under TB. But remember, TB meningitis is still the commonest form of chronic meningitis which is seen in our patients. However, cryptococcal meningitis is also a very important cause of chronic meningitis. Next slide. So cryptococcal disease, out of which cryptococcal meningitis is one of the manifestations. It is an opportunistic infection that occurs primarily among people living with HIV disease who have advanced HIV disease. It is caused by an encapsulated yeast, which is called Cryptococcus neoformans, or some other forms of Cryptococcus gattii infections. It is very important to know that nowadays we are able to diagnose cryptococcosis, meaning the presence of cryptococcus in the body, by detection of through a very simple technique which is called detection of cryptococcal antigenemia, meaning we are able to detect the cryptococcal antigen in the serum of these patients, and that can actually predict the presence of cryptococcal meningitis, which is a far more serious form in these patients, especially those who have advanced immune suppression. Cryptococcal meningitis is a very, very important cause of mortality among AIDS-related deaths, and almost 15% of patients of AIDS-related deaths are directly attributed to cryptococcal meningitis. It's a very, very important cause of meningitis, especially in Sub-Saharan Africa, but it is also a very important cause. It is mostly underdiagnosed in places like India, but it is also a very important cause of chronic meningitis here. The reason why it is either underdiagnosed or not detected is that, and it has a high mortality, is that there are numerous challenges to it. Number one is anybody with a suspect meningitis, for that matter, and especially cryptococcal meningitis, should have a lumbar puncture to detect the presence of either the organism or the antigen. And so there is limited access to performing a lumbar puncture and the CSF analysis. So that is one of the biggest challenges. And rapid diagnostic assays, like I was talking about, the antigen detection assays are not available still in our country freely and everywhere. So we still rely on some of the older techniques like India ink demonstration of the organism, which is not a very sensitive method. And again, it is not available everywhere. So because of these two reasons, it is not, it's a very, very difficult disease to treat. Another thing which is very difficult about cryptococcal meningitis is that it requires very, very sophisticated kind of treatment with amphotericin B, especially liposomal amphotericin B and flucytosine, and the availability and the access to these medications also is a major challenge, and also it's a very, very expensive medication. So again, if it is not provided by the health system, it is very, very complex for patients to get treated, and there is also a very high degree of recurrence of cryptococcal meningitis. That is why cryptococcal meningitis is one of the most difficult OIs to treat in people living with HIV/AIDS. Next, please. So how does it present? It is a cause of subacute meningitis or chronic meningoencephalitis. But it is important to remember that it does not present with the classical features of meningitis like headache and fever and vomitings, but rather it presents early on with very non-specific symptoms like very prolonged persistent headache, and maybe very mild fever. In fact, patients may not even notice to have fever because the fever is so mild, but headache is always early, and headache is always a very prominent symptom which is seen in these patients. And like I said, approximately 65 to 75%, that is almost 3/4 of the patient, will not have the classical features of meningitis, that is headache and neck rigidity, and all your neck signs will not be demonstrable easily in these patients. However, as the disease progresses, there are more and more neurological manifestations which appear, including altered sensorium, and later on there can be neck stiffness, and cranial nerve abnormalities can also be manifest. In addition to cryptococcal meningitis, patients may have dissemination of cryptococcal disease, and it is very commonly seen that patients, in addition to cryptococcal meningitis, may also have a cutaneous form of cryptococcosis, as is seen in this gentleman on the slide, where you can see these nodular lesions which are there all over the face. And there are multiple etiologies for such nodular lesions, and one of the common differential diagnosis always is molluscum contagiosum, but also disseminated histoplasmosis involving the skin. Sometimes other lesions can also present like this. So sometimes it becomes very difficult to detect cutaneous cryptococcosis, and there can also be pulmonary cryptococcosis in the same patient. So dissemination happens when patients are very severely immune suppressed. Next. So let us look at how to diagnose cryptococcal infection. Remember, what we are talking about is diagnosis of cryptococcal infection, not necessarily cryptococcal meningitis. Cryptococcal infection means presence of cryptococcus within the body of the infected subject. Cryptococcal meningitis is very specific when there is meningeal or meningoencephalitic involvement seen in these patients. So you can detect cryptococcus by three methodologies. Number one, you can either test for the antigen of cryptococcus, that is called the cryptococcal antigen, or you can detect the organism by microscopy, or you can detect the organism by culture. So let us see where we can do the antigen detection tests. The antigen detection test can be done either in a sample of serum or CSF. So you can do a serum or CSF antigen test, which is called the CRAG, cryptococcal antigen or CRAG test. It can be done both in serum or CSF. And the ideal method of doing it would be the lateral flow assay or an LFA. Lateral flow assay is a very simple bedside test which can be done by anybody. It does not require any training. It is a very simple strip test. However, it is not still very easily accessible, and many laboratories still use cryptococcal antigen detection by the latex agglutination method. That is also a good method, but that requires a sophisticated lab that can be done only in a lab. Whereas a lateral flow assay is a very simple strip-based test which can be done at the bedside, and it is relatively very inexpensive also, and it can be done on the serum also. It is important to remember that. By microscopy, that can be done only in the CSF in patients with suspected cryptococcal meningitis. By microscopy, you can identify the organism, which is the yeast. You can look at the budding yeast forms. And classically, you do it in what is called the India ink preparation or the India ink staining. You can also use a gram stain. The common gram stain can also be used. However, there is a problem with the India ink preparation in that, again, it is not very easily available across the country. And number two, it has a problem with sensitivity. It picks up in cryptococcal yeast forms in only about 60 to 80% of cases, which means that in about 20 to 40% of cases, it can actually miss cryptococcal yeast forms. So it is not a very sensitive test, whereas the antigen detection test is very highly sensitive and very specific also. Of course, the culture is the gold standard, and if you're able to grow cryptococcus in a culture medium, it is the best modality of diagnosis. However, it will require a very sophisticated microbiology lab, and it will require a microbiologist to culture the CSF, and it is not available at most places in the countries. At least in most ART centers will not have access to a CSF culture for cryptococcus. Another way of identifying or suspecting cryptococcal meningitis would be when you do a CSF analysis after a lumbar puncture in these patients. It will show mildly elevated levels of protein. The glucose levels may be normal or low. And most importantly, there will be pleocytosis, meaning there will be increase in CSF cell content, most of it again be lymphocytes, and there will not be too many cells. Classically, in TBM, you see many cells in the range of 200s, 300s, or even up to 500. In pyogenic meningitis, you see in 500s to thousands. But in cryptococcal meningitis, classically, it is about 50 to 100 cells. Most of them are lymphocytes. But it is very important to note that the opening pressure in CSF, if you are able to measure CSF opening pressure with a manometer, is very high. It is more than equal to 25 centimeters of water, and it occurs in 60 to 80% of patients. So it is a very, very important feature of raised ICT in these patients. Whenever we suspect a patient of having cryptococcal meningitis, a prompt lumbar puncture, measurement of opening CSF pressure, and also a rapid CRAG assay is recommended as a preferred diagnostic approach. Remember, this is the preferred diagnostic approach. However, if CRAG is not available, then you must go ahead with the India Ink preparation of a stained smear of the CSF. Next, please. So now let us look at the diagnostic approach depending upon the type of facility and whether or not a facility has access to some of these tests. One of the biggest challenges to treating cryptococcal meningitis in Sub-Saharan Africa is that they don't even have the capability or they don't have access to performing a lumbar puncture. So if there is such a situation where one of our ART center patients is facing is that you are suspecting cryptococcal meningitis, yet you do not have access to lumbar puncture, yet you can still think patient could be having cryptococcosis, the simplest thing to do is you can do a serum or blood or plasma CRAG, which is there on the right hand side of the column. Suppose let us go by what is said in the table. If a CRAG assay is available and the setting has no contraindication and there is access to lumbar puncture, then the preferred treatment would be to do a lumbar puncture and then subject the CSF to a rapid CSF CRAG assay. If you don't have CRAG, then you do a lumbar puncture and subject the CSF to an India Ink test for examination for the budding yeast form. Suppose you are in a position or you are in a place or somehow you are not able to perform a lumbar puncture because it is clinically contraindicated, patient may be having evidence of very severe raised ICT clinically, then you would not like to do the lumbar puncture, then you can actually do a serum plasma or whole blood CRAG, which is a surrogate marker of cryptococcal meningitis. And of course, if you don't have CRAG, then the best in such a situation would be refer the patient to a higher center where probably one or these other investigations is available so that patient gets the best standard of care in case you're not able to do a lumbar puncture and you don't have facilities for a serum CRAG. Next. So there are some things you have to ask, there are some things you have to look for or assess, and then there are some things you have to investigate for to diagnose cryptococcal meningitis. Ask for the onset of symptoms suggestive of meningitis. Do not miss out the non-specific symptoms. Many times patients may not have severe headache or severe fever or high neck rigidity. These signs may be missing. So remember, ask about these signs. Remember, cryptococcal meningitis can manifest as an iris. So you must ask about the ART initiation if it has happened, and if it has happened, on what duration patient has been on ART, to look for the temporal association between ART initiation and cryptococcal meningitis. Like I said, one of the differential diagnoses for cryptococcal skin lesions is molluscum. So if there is umbilication of the skin lesion, it goes more in favor of molluscum. If umbilication is absent, it goes more in favor of cutaneous cryptococcosis. But sometimes these are very difficult to differentiate clinically because the lesions can be very small, and especially in dark-skinned persons, it is very difficult to look at these minute skin changes. Serum CRAG, remember, serum CRAG is indicated in all PLHIV who present with CD4 cell count less than 200 with or without symptoms suggestive of cryptococcal meningitis. And this was one of the questions which was there in your pre-test. Anybody, all PLHIV with CD4 count less than 200 should have a serum CRAG testing. This is a recommendation which is now there in our national guidelines, though it has not yet been implemented across many centers because of the availability of the serum CRAG. But it is a recommendation nonetheless that ideally all patients with a CD4 count less than 200, that is those who have advanced HIV disease, should have a serum CRAG at baseline. Among these patients, if they have headache and have features suggestive of meningitis, then a lumbar puncture is indicated. All patients with a positive CRAG should be referred for a lumbar puncture because a serum CRAG may be a surrogate marker of cryptococcal meningitis. And like I said, the sensitivity of the India ink is not very good. So a negative result on an India ink preparation of the CSF smear is not good enough to rule out cryptococcal meningitis. Patient could still be having cryptococcal meningitis because the sensitivity is only about 60%. Next slide. So let us look at some aspects of screening for cryptococcal disease. So now the WHO and NACO guidelines for advanced HIV disease have come out with this recommendation that screening for CRAG in the blood followed by what is called preemptive antifungal therapy among CRAG positive people to prevent the development of invasive cryptococcal disease or cryptococcal meningitis is recommended before either initiating or reinitiating ART for all adults and adolescents living with HIV who have a CD4 count less than 200 cells per cubic millimeters. However, screening is still not recommended for children less than 10 years because of the low incidence of CM in this age group. And like I said, serum CRAG lateral flow assay is reliable, robust, easy to perform, and should be used in centers where it is available. And in any PLHIV with less than 200 cells, it should be used before you initiate ART. Next. So let us see what happens when you do a serum CRAG. So all patients with CD4 cells less than 200, you are doing a CRAG. All right. Suppose the serum CRAG is positive, and then you have done a CSF also, and the CSF CRAG is also positive, then the patient is treated as cryptococcal meningitis. Suppose the serum CRAG is positive, and you are not able to perform a CSF CRAG, either the CSF is not possible or the CRAG is not available, then if the patient is symptomatic, you will treat for cryptococcal meningitis. However, if the patient does not have features of meningitis, then you will give preemptive treatment because serum CRAG is positive. If, however, the serum CRAG is negative, then patient is symptomatic for meningitis or having some other neurological symptoms, you will look for other causes. And of course, if serum CRAG is negative and patient is asymptomatic, you will deliver the rest of the standard package of care. Now comes the question which many of us are facing is, serum CRAG is not feasible or not available. It has not been rolled out across our country, so maybe it is not available with many ART centers. Suppose it is not available, then what do you do? If patient is symptomatic for meningitis, then you will do a CSF and then go ahead with diagnosis of meningitis like we normally do. And if the patient is asymptomatic, but the CD4 count is less than 100, then we will give fluconazole primary prophylaxis, meaning the patient is treated as primary prophylaxis. All right. I hope this slide is clear. Next. So what do you mean by preemptive treatment? Preemptive treatment is we are offering antifungal treatment to all asymptomatic PLHIV who test positive for serum CRAG by a CRAG test. That means they have cryptococcal infection, but they don't have cryptococcal meningitis. So everybody who screens positive or tests positive by serum or plasma, What you should first do is you should evaluate them very carefully to see if they are having any feature suspicious of cryptococcal meningitis. If they are even having some feature suggestive of cryptococcal meningitis, you should perform a lumbar puncture. Otherwise, such asymptomatic patients should be given preemptive treatment, which can also be given to pregnant women. But however, proper counseling is required because fluconazole is not a class A recommended drug. So counseling should be provided to all the expectant mothers who are CRAG positive. Next. So what is the preemptive fungal antifungal treatment we give fluconazole. It is given again in an induction phase, a consolidation phase, and in a maintenance phase. For an adult, we give 800 milligram per day of fluconazole. For a child, 12 milligram per kg per day. For an adolescent, sorry, for 2 weeks. So after an induction phase of 2 weeks, we go on to a consolidation phase. The same dose of 800 milligram per day for adults and 6 to 12 milligram per kg per day for children and adolescents, up to a maximum of 800 milligram per day for a further 8 weeks. Then you have a maintenance phase of fluconazole given 200 milligrams daily for adults, 600 milligram per kg per day for children and adolescents, till evidence of immune reconstitution, which means you are now going to monitor the CD4 count and then determine whether you can stop preemptive antifungal treatment or not. So till such time, the patient will continue fluconazole at 200 milligram per day for an adult. Next. It is very, very important to remember that in adults and children with HIV in whom you have diagnosed cryptococcal meningitis, very important, in whom you have diagnosed cryptococcal meningitis, ART initiation is to be delayed. This is one of the probably only indications where you delay ART initiation and you defer it by 4 to 6 weeks from the initiation of antifungal treatment because of the risk of very high mortality if you start ART early in these patients. So anybody diagnosed as CM, you will defer or postpone ART by at least 4 to 6 weeks, even more, depending upon the clinical condition of the patient. So it should be initiated only after 4 to 6 weeks after successful antifungal treatment. This is very important to remember. Many times ART centers get referrals from neurology departments, from medicine departments for initiation of ART in patients with CM. Please remember, ART is not to be initiated immediately upon diagnosis of cryptococcal meningitis, and it has to be deferred for at least 4 to 6 weeks after successful antifungal treatment. So that is a long time. Please remember this and write that down on your file without even a worry, because you don't start ART immediately in these patients. Next. So let us look at primary prophylaxis. What is primary prophylaxis? Primary prophylaxis means you are treating, preventing cryptococcal infections at all without any evidence of cryptococcal infections. But however, it is no longer recommended because now we are screening for CRAG, and so and fluconazole has a lot of toxicity, so it is no longer recommended. However, if CRAG test is not available, then for those patients in whom CD4 count is less than 100, you may give fluconazole 100 milligram per day. And for when do you discontinue preemptive treatment or primary prophylaxis? You discontinue it after at least give it for 1 year, and CD4 count is more than 100 cells per millimeter cube, and the patient has suppressed viral load, that is plasma viral load is less than 1000 copies. So patient has adherent to ART, free of cryptococcal disease, fluconazole has been given for at least a year, CD4 count is more than or equal to 100, and patient is virologically suppressed. All these criteria have to be met, not one. All of them have to be met. Only then you will discontinue fluconazole primary prophylaxis. Next. So let us look at the treatment of cryptococcal meningitis. So this is a person in whom we have done a CSF and we have proven either through CRAG or through India Inc. or through culture that patient has CM. How do you treat it? You treat it again with an induction phase, a consolidation phase, and a maintenance phase. You give an induction phase treatment with amphotericin B, 1 milligram per kg per day, and flucytosine. It is and flucytosine, 25 milligram per kg for 1 week, which is followed by fluconazole 1200 milligram per day for adults or 12 milligram per kg per day for children and adolescents. Maximum in children and adolescents is 800 milligram per day for 1 week. So remember, the first week is a combination of amphotericin B and flucytosine. The dose of 1 milligram per kg per day is conventional amphotericin B. The dose for liposomal amphotericin B is higher. It is between 3 and 5 milligram per kg per day, but this is conventional amphotericin B. Suppose you don't have amphotericin B or flucytosine access in your institution, you can then give either just 2 weeks of fluconazole, 1200 milligram per daily for adults, and flucytosine, or you can give 2 weeks of amphotericin B and fluconazole if flucytosine is not available. So remember, in case amphotericin B is not available, then you combine fluconazole with flucytosine. If flucytosine is not available, then you combine amphotericin B with fluconazole. However, it is always a combination treatment given for the first 2 weeks, and that is very important to remember in the induction phase of cryptococcal meningitis. And it is important that amphotericin B, flucytosine, and fluconazole will have to be made available by the local SACs or the institution. And the ART medical officer has to requisition either the SACs or the local institution, medical superintendent or director or dean, for the procurement of these drugs, which are life-saving for these patients. Next. This is followed by a consolidation phase. After 2 weeks of induction phase, you give fluconazole 400 to 800 milligram daily for adults. I'm going to restrict myself to adult dosing. The children and adolescent dosing is written and you can read it. Fluconazole 400 to 800 milligram per day for adults for 8 weeks. And then you maintain it with secondary prophylaxis of 200 milligram per day for adults. And when do you discontinue secondary prophylaxis? That means this is a patient who has had CM and you are giving secondary prophylaxis with fluconazole. It is recommended that it can only be discontinued if patient is adherent to ART and is free of clinical cryptococcal disease, has been given for at least 1 year, CD4 count is at least more than 100 cells, and the patient has a suppressed viral load of less than 1000 copies per ml. So remember, by this time, patient should have been started on ART and should be virologically suppressed. Only then can you recommend stopping secondary prophylaxis with fluconazole. So it is a very complicated, long treatment of cryptococcal meningitis. Next. It is also seen that one of the most important causes of mortality in these patients who have cryptococcal disease is raised intracranial tension, and you find that these patients often decerebrate, have seizures, and have clinical features and symptoms and signs of raised intracranial tension. And if the CSF opening pressure is elevated, you can remove some CSF at the time of lumbar puncture by about 20 to 30 ml, and that reduces the intracranial pressure. But however, this should be done only by a person who knows how to do this, and this has to be done only in the setting of a ward or an indoor patient. You cannot attempt this as an outdoor procedure because it can give rise to sudden coning and sudden death. So you have to be very careful. Sometimes you can, instead of removing it, you can do serial lumbar punctures every day and drain a little bit of CSF, which will reduce the CSF pressure. Also, sometimes you may need to put a lumbar drain or a ventriculostomy or some other form of surgical intervention may be needed to reduce the CSF pressure. Also, you have to keep treating with medical treatment such as with mannitol, acetazolamide, and actually corticosteroids are not recommended. In fact, they are contraindicated in patients with cryptococcal meningitis. So please do not treat them with steroids. Mannitol will have very little effect. It will have effect for maybe 24 hours or for 72 hours maximum, but you will have to remove the CSF repeatedly to reduce the CSF pressure in these patients. So these patients need to be hospitalized, admitted, and monitored very closely. Next. So liposomal amphotericin B is preferred over conventional amphotericin B. However, it is due to much less adverse effects, especially of creatinine rise and hypokalemia. However, it is much more expensive, and amphotericin B should be reconstituted in sterile water, and that is how you administer it in 5% dextrose. And you can give it in a peripheral IV line, and the solution should be infused over at least 4 hours, and you need to monitor potassium, you need to monitor creatinine on daily basis, because these are toxic drugs, and you need to monitor especially potassium and creatinine very closely in these patients. Next. Patients should be well hydrated to prevent renal injury in these patients, and potassium chloride, like I said, should be infused prior to this, and you keep on monitoring and giving supplements with either oral or potassium or with IV potassium, and flush the IV lines with normal saline. These are some measures to reduce infusion related reactions in these patients. I will not go into details, you can refer to these slides, but it is important to remember that creatinine can rise and hypokalemia, that potassium can be low, can fall in these patients. And these are two important side effects or adverse effects of amphotericin B that one must remember. Next, please. Like I said, there can be infusion related reactions, that is febrile reactions, which can be treated with paracetamol, and if severe, a small dose of steroids. And of course, like I said, you need to monitor lab values in these patients. Next. It is very important to remember these patients can have frequent relapses, and relapses occurs because either the induction therapy was inadequate, you have given a single drug, or you gave suboptimal dosing of the drug, or the patient was not adhering to the fluconazole therapy, secondary prophylaxis, or sometimes some rare forms of cryptococci are resistant to fluconazole. So you can have fluconazole resistance in these patients, and so that can give rise to relapse. And there can be other rare structural damage that cryptococcus can cause. And of course, if patient is not responsive to ART and is having biological failure, patient can have a relapse again of cryptococcal meningitis. You treat similar to the first episode as a relapsed episode, same way. There should be no change in treatment. You again treat it the same way. Next. Iris, it can present, it is one of the common causes of iris. It usually happens weeks to months after ART initiation, and higher white cell count is there because remember, now these patients are immune reconstituted. So the low CSF cell count is replaced by a higher CSF cell count. So you will have a florid leukocytosis reactions. And again, raised ICT will be there. Focal mass lesions of cryptococcal mass can be there. Again, if you're suspecting paradoxical CM iris, you should do a lumbar puncture, reduce pressures. And again, in this situation, because it is an iris, you should try and monitor the patients with a fungal culture till patient becomes fungal culture negative. It is important, and you need to extend the incubation of the fungal culture for up to 14 days. So it is better these patients are treated in a setting where this kind of management and monitoring is possible. Next. So one must always, in addition to cryptococcal meningitis relapse, thinks of all other forms of chronic meningitis like other fungi, TB, bacterial meningitis, viral meningitis, or space occupying lesions, and those must come as your differential diagnosis before you think that it could be a relapse. And of course, I think anybody will do these investigations at the time, and you must also get an MR of the brain done for these. And generally, it is better these patients are managed in a setting where advanced care can be provided to these patients. Next. All right, so this is a rather complex table for screening and management that tries to put everything together. So the patient presents to the nurse who does the forest screening, looks for if the patient is having persistent headache or altered sensorium, or is unable to walk, or has paralysis, and assesses for signs of serious illness. Patients with fever of more than 39, with headache, high respiratory rate, high heart rate more than 120, and or an SpO2 of less than 90, they are confirmation, or they are signs of advanced or serious disease. So if none of these are present, then you look whether symptoms of meningitis are present, like confusion, headache, fever, neck stiffness, or photophobia. If serious disease is present, the patient should directly be admitted and into the medical emergency, and from there, if required, a neurological emergency, and then should be appropriately managed. If a patient has evidence of symptoms of meningitis but is not seriously ill, then you perform a serum CRAG. If the serum CRAG, and then you can refer to an appropriate expert for performing a lumbar puncture, because remember, the ART center MO will not be able to do a lumbar puncture in the ART center. Patient has to be admitted indoors. So you will have to refer the patient to your emergency department, where patient has to be admitted and a lumbar puncture has to be done, and all other tests to rule out all other meningitis have to be done. Now, suppose symptoms of meningitis are absent. We go on to the next slide. Symptoms of meningitis are absent. Then you will look at the CD4 count. If the CD4 count is more than or equal to 200, you will provide the same standard of care. If, however, CD4 count is less than 200, or the patient is in WHO clinical stage 3 or 4, which means this patient has advanced HIV disease, you will perform a serum CRAG at the ART center. If the CRAG is negative, then nothing is needed. You will provide the usual advanced disease management package of care, but no fluconazole is needed. However, if serum CRAG is positive, if possible, perform a lumbar puncture. And if lumbar puncture is CSF CRAG is also positive, you will treat for cryptococcal meningitis. If, however, CSF CRAG is negative, or there is no indication of doing a CSF, then you will start preemptive treatment for aseptic cryptococcemia with fluconazole 800 milligram per day for 2 weeks, then 400 milligram per day for 4 weeks, and then you continue for 200 milligram per day, like I told you. And it is recommended that these patients, if you're going to initiate ART, you will recommend 2 weeks after initiation of treatment for asymptomatic cryptococcemia. Next slide. Okay, now we need to move a little faster. We have taken a long time in cryptococcus, but that was a very, very important subject that we needed to cover. We're going to go to toxoplasmosis. Next slide. Toxoplasmosis causes an encephalitis, which is caused by a protozoan called Toxoplasma gondii. We rarely see toxoplasmosis now. We used to see a lot of toxoplasmosis about 10 years back or maybe 15 years back, because at that time, why has this happened? It is not because toxoplasma has gone away. It is still there. It is present everywhere. However, since we are giving cotrimoxazole prophylaxis very early to our patients, anybody with a CD4 count less than 350 is getting CPT, and we are initiating ART early. Very rarely we do come across a toxo now. It occurs by eating contaminated food contaminated with oocytes of cat feces, or from tissue cysts in undercooked meat from domesticated animals. So basically, it is a matter of food hygiene. It remains one of the most common causes of focal lesions in PLHIV after tuberculoma. I would put tuberculoma also very commonly seen in India. It is rare in patients with CD4 count more than 200. That is why, because you are initiating ART early in all patients, and you are also giving CPT prophylaxis below 350 in our patients. So only patients who have very low CD4 counts less than 50 are at the greatest risk for developing toxoplasma, and it is not transmitted from person to person contact. Next slide. It presents as a focal cerebral syndrome. So it presents with headache, confusion, focal deficits, and or fever sometimes. Patients may also sometimes present with non-focal manifestations because of the encephalitis, and can present with neuropsychiatric manifestations and non-specific headache. And on examination, there may be focal neurological deficits. It can result in seizures, stupor, coma, and death if untreated and undiagnosed. And the classical picture or the classical diagnostic test for diagnosis of toxoplasmosis is a CT scan or an MRI of the brain, which will typically show multiple contrast enhancing lesions in the gray matter of the cortex or the basal ganglia, often with some perilesional edema. Also, sometimes single lesions can be seen, but these lesions are very classical and they can be very easily differentiated by your radiologist who is trained between tuberculoma and toxoplasmosis. Next slide. So if you look at the picture here, there are multiple ring enhancing these white lesions that you see in the brain. Multiple of them. There are there in the cortex. They are in the posterior cortex also. And you can see that there is a large area of black tissue around it, which is the perilesional edema. So multiple, in fact, they are coalesced at many places, multiple ring enhancing lesions. It is very important to remember that both serum IgG and IgM antibodies do not indicate active disease. So you really cannot decide whether to treat or not to treat on the basis of the antibody test. It is very important to remember that. PCRs can pick up the toxoplasma nucleic acid, but they are very low sensitivity, and of course they are not available at most places. CT and MRI is a way in which you will diagnose it. They are usually ring enhancing and have a predilection for the basal ganglia. But of course, none of them, like I said, it can be very confusing and it can be confused with tuberculomas. A single lesion can be confused with a lymphoma. So it is important to remember that there can be other confounding features of the MRI brain. But definitive diagnosis requires a compatible clinical history and identification of one or more lesion, and if possible, detection of the organism in a clinical sample. But this is something which most of us are not able to achieve. Next. So ask for symptoms of headache and confusion, ask for symptoms of seizures. Most of them will have seizures and stupor. Look for motor deficits, focal deficits, because it is a focal cerebral syndrome. Look for MRI, multiple enhancing lesions which diagnose toxoplasma encephalitis. Always perform the imaging first. If required, you do a lumbar puncture. Normally, it is not required for diagnosis of the toxoplasma. You may want to do the LP for ruling out other diagnoses, but if you have multiple focal ring enhancing lesions on your MRI brain, you generally will not attempt a CSF, a lumbar puncture in that situation. Next. So then you differential diagnosis, like I said, I have already discussed most of them: PML, lymphoma, tuberculoma, fungal infections like cryptococcosis, very rarely Chagas, we don't see it here. Pyogenic brain abscesses, multiple, especially in IV drug abusers. These are some of the important differential diagnosis of the lesions of the brain. Next. So how do you manage toxoplasma encephalitis? The preferred regimen, remember, the total duration of treatment is 6 weeks. The preferred regimen is a combination of pyrimethamine given as 200 milligrams per oral once, followed by a dose-based body weight. For body weight less than or equal to 60 kgs, pyrimethamine 50 milligram once a day plus sulfadiazine 1000 milligrams plus leucovorin to prevent folic acid problems. So you can give leucovorin also. For body weight more than 60 kg, pyrimethamine 75 milligrams plus sulfadiazine 1500 milligrams plus leucovorin 10 to 25 milligrams. Now what happens is that sulfadiazine is most often not available very easily. So in that situation, you can give pyrimethamine plus clindamycin, which can be given IV as 600 milligrams IV or per oral. They have almost the same bioavailability. It has to be given 4 times a day. Either you are intolerant to it or there is a problem with that. The third alternative which we can give and which we usually give is Septran or cotrimoxazole, given in a dose of 5 milligram per kg trimethoprim or 25 milligram per kg sulfamethoxazole per oral twice a day. So it is important to remember the dosing of Septran that has to be given for these patients. The total duration of this treatment has to be 6 weeks. Next. There is a chronic maintenance therapy for patients who have a toxoplasma encephalitis. In that, you can give it, the preferred regimen again would be pyrimethamine plus sulfadiazine. However, the alternatives will remain to be clindamycin or trimethoprim, sulfamethoxazole, or Septran or CPT, given as one tablet, double strength BD, or one double strength OD. And when you discontinue it, you have after successfully completing the initial therapy, the patient remains asymptomatic and the CD4 count is more than 200 cells for at least 6 months in response to ART. This is the indication for discontinuing this entire treatment. All right. But this is not the indication for discontinuing CPT prophylaxis for all patients. So there is a difference. If you're giving pyrimethamine plus sulfadiazine, you will give it for 6 months. All right. Next. So prophylaxis can be primary prophylaxis or secondary prophylaxis. Primary prophylaxis we are using for toxoplasma encephalitis because we are giving patients CPT, cotrimoxazole prophylactic treatment, and it prevents PCP, it prevents toxoplasmosis, and it also prevents multiple other bacterial diseases. And the double strength tablet of once daily dose of cotrimoxazole CPT is a preferred regimen for PCP prophylaxis. Is also effective against toxoplasma and is recommended. Of course, if a patient is allergic to CPT, then you can give dapsone 100 milligram once a day. Desensitization has been recommended in books and in literature. However, it is difficult to perform. So it is better to use an alternative of dapsone 100 milligram once a day for these patients as prophylactic treatment for toxoplasma. Next. We will go on to Cytomegalovirus disease, CMD. Next. CMV is a very important infection which can involve the central nervous system. It is a double-stranded DNA virus of the herpes virus family. Usually causes disseminated disease involving the GI tract, causing colitis. It can cause ulcers. It can cause retinitis, which presents as the neurological manifestation. And retinitis or Cmb retinitis is the most common CMV-related end organ disease. It usually occurs in children again who have been patients who have been previously infected with CMV and who have a CD4 count of less than 200, and either it is a reactivation or it's a latent infection. It is important to remember that it may remain asymptomatic because you really don't look for or ask for these questions of loss of vision, because it is taken that when patients are very seriously moribund, they really don't focus much attention on whether there is losing vision or there is diminution of vision, and so it may remain asymptomatic for a very large period of time. Next. So the retinitis commonly presents as a very common end organ damage in PL-HIV. Peripheral retinitis, if it doesn't involve the central area of vision, it may be asymptomatic because it's lying peripherally in the field of vision. It can present as scotomas or visual field defects with some floaters, but you have to test to find out the visual field defect. But central lesions which involve the optic disc, they can cause decreased visual acuity and they can present with decreased central field defects and can present with blindness, where it becomes very symptomatic. Classically, you can diagnose it by doing an ophthalmological examination. You see these fluffy yellow-white retinal lesions with or without intraretinal hemorrhages and very little inflammation of the vitreous. And invariably, it rapidly progresses within 10 to 21 days, and it's a medical emergency because it can cause irreparable blindness if not promptly treated. It is a medical emergency. If you have Cmb retinitis, you have to intervene fast. You cannot wait till sometime the drug is coming. No, it will result in loss of vision of one eye, and very quickly it will involve the other eye also. So patient will have bilateral loss of vision very quickly if you don't intervene. Next. So colitis, esophagitis, and other neurological diseases are other manifestations of CMV disease. Colitis presents with weight loss, anorexia, GI bleeding, debilitating diarrhea, and malaise. Sometimes can cause perforation and can present as an acute abdomen. Esophagitis presents just like an esophageal ulcer with odynophagia, difficulty in swallowing, painful swallowing, and on an upper GI endoscopy, you may actually see a large ulcer. And if you do a biopsy from the ulcer, you will be able to demonstrate CMV in that. And it can also cause, in addition to retinitis, dementia, ventricular encephalitis, polyradicular neuropathies, and some other forms like GBS kind of a syndrome. So these are the other clinical features of disseminated CMV infection. But we talked about CMV retinitis earlier. Next. So ask any patient who is having ART failure or who has low CD4 counts less than 100, ask about diminution of vision or floaters. Assess, test for visual acuity and see if there is visual loss. Immediately refer to an ophthalmology department to assess the eyes if any patient is complaining of loss of vision or diminution of vision. Even on simple indirect ophthalmoscopy, you can look for these retinal lesions, which are so classical and so characteristic. Next slide. So if you look at the fundus picture, this is classically what is seen. Just a fundus examination by an experienced ophthalmologist is all that is required, and it has a very strong positive predictive value. It is called tomato ketchup appearance, it's called pizza pie appearance, multiple brush fire appearance. All these are different names given to these fundus appearances. You can do a blood test to detect CMV antigen in the blood or culture or PCR, but again, these are very poorly predictive. And somebody who has low CD4 count, is HIV positive and has loss of vision and has such a fundus picture, it is most likely to be CMB retinitis. You don't need to do any further tests. If you do a CSF, it may show some pleocytosis, usually lymphocytic predominant. Next slide. But it is a medical emergency. You must refer the patient to ophthalmology department with a referral letter. Patient will require extensive treatment with very expensive drugs of valganciclovir for a very long time. So you must requisition the drug from Saks, because it is very important, because it has to be treated for a long time, for at least 3 to 6 months. And you have to monitor these patients again beyond 3 to 6 months also to look for the response to treatment. And you can discontinue treatment only on the consultation with an ophthalmologist looking at the activity of the retinal lesions, not just a CD4 count based analysis is enough to discontinue treatment for CMV retinitis. And every 3 months, an ophthalmological follow-up is required. So you will need to work very closely with your ophthalmologist for treating these patients who are having CMV retinitis. Next. And you treat them with antiviral drugs. The preferred therapy is valganciclovir, 900 milligrams given orally every 12 hours for 14 to 21 days, and then 900 milligrams once a day for a very long period of time. Alternatively, and before valganciclovir was available, we were using ganciclovir, 5 milligram per kg. We were giving IV for about 14 to 21 days, and then 5 milligram per kg IV daily. Or you can give it IV for 21 days and then follow it up with oral, depending upon what is the extent of lesions, how much is the lesion active, what is your ophthalmologist favoring treatment. So you have to work with that. Also, sometimes intravitreal injections of ganciclovir or forscarnet are given by your ophthalmologist. If they will help in healing these lesions faster, but that can only be done by an ophthalmologist. And you can switch from IV ganciclovir, which is far more expensive, to oral valganciclovir, which is relatively inexpensive, but you have to give it for a very, very extended period of time. Another alternative treatment is forscarnet, which can be given IV. Next. When you stop treatment, you have to give for at least 3 to 6 months till the lesions are inactive and CD4 count is more than 100 for at least 3 to 6 months after ART response. And your ophthalmologist has to be the one to tell you to stop treatment, and only then you will stop. And if the CD4 count falls below 100, you will again reconstitute the chronic maintenance therapy for patients with CMB retinitis. Remember, CMB retinitis can also present as an iris. So it is very important to remember that. Next. For peripheral lesions, you can give the same thing for about first to 3 to 6 months, because peripheral lesions don't give rise to too much loss of vision because they are more peripheral field defects. But again, you may have to work closely with the ophthalmologist to decide how long and what kind of treatment you want to give to your patient. Next slide. CMB esophagitis or CMB colitis or gastrointestinal disease, again, you give for 21 to 42 days ganciclovir, followed IV followed by oral valganciclovir if the patient is able to tolerate. Alternatively, foscarnet can be given IV, initially TDS and then BD, or if it's having a milder GI disease, you can continue with oral valganciclovir for a very long period of time. Next. For other neurological disease and pneumonitis, the treatment doses are the same as that for retinitis. However, you must rule out all other causes. But remember, in patients with other forms of disease like neurological disease or pneumonitis or disseminated disease, the exact recommended duration of treatment is not very clear, and you have to go on a case-to-case basis to see what has to be done in these patients. Next, please. Dr. Amit had a question. Dr. Amit, if you had a question.
No, ma'am.
He had raised his hand, so I thought maybe.
Okay.
Okay, we will very quickly go to meningitis. Let us see if we can cover most of this. Meningitis, next slide. Meningitis has multiple causes. Tuberculosis, cryptococcal, aseptic, bacterial, these are the main causes. Next slide. And how we differentiate them is on the basis mainly of the clinical features, the course of disease, the lumbar puncture, and the CSF analysis. And depending upon what is the etiology, you will treat it. Aseptic meningitis usually caused by HIV infection itself or some of the other viral illnesses, usually lymphocyte predominant, usually mildly symptomatic patients, so generally subsides with just simple care. Nothing much elaborate needs to be done for aseptic meningitis. Next one. Bacterial meningitis caused by bacteria like staph, strep, H. influenzae, Nyseria meningitis, presents with classical features of meningitis, short duration of fever. The CSF is polymorphonuclear, predominant, high protein, very low sugar, very turbulent to look at. Gram stain may reveal the organisms. Culture may grow the organisms. CT or MRI may be required for locating some focal neurological deficit, and treatment is with course of antibiotics. Next. Third generation cephalosporins like ceftriaxone and or vancomycin is what is usually required for these patients. Treatment should be given IV for about 10 to 14 days. Next. TB meningitis presents as a chronic meningitis, will be dealt with in much more, treatment of TB will be dealt with much more when we talk about TB treatment. But again here, this is a lymphocyte predominant CSF, high proteins, low to normal sugar, and it will not, you can detect ADA positivity may be there. You can also sometimes detect TB PCR in these things. Next, ATT has to be given along with steroids. The most important thing is to do a CSF, and it can differentiate on the basis of cells, on the basis of biochemistry and microbiology between Cryptococcus, TBM, bacterial and syphilitic meningitis. And this table is something that you need to refer to when you are suspecting patients having meningitis. Next slide. PML, I don't know. Do we continue beyond 3:30?
Ma'am, if we can finish in another 10 to 15 minutes, we can
Right.
continue.
We will finish with by 3:40. I think we should finish.
Yes, ma'am.
We will go to PML, which is again a very, very important entity. Next. PML is caused by a virus which is called JC virus, also called the John Cunningham virus. It's a polyoma virus. Classically, because of immune suppression, it happens in the setting of HIV infection, which reactivates the virus, causing destruction of the oligodendrocytes and a debilitating demyelinating disorder. About 3 to 5% of incidence is seen in patients with HIV and can sometimes occur even after treatment with ART, and it can be very debilitating a disease. Next. It is one of those rare, diseases or manifestations where ART is what is required to be given in these patients. It presents as focal neurological deficits, insidious onset, steady, progressive disease. They involve multiple areas of the brain, and so cerebellar involvement is seen in almost 1/3 of patients. So patients can become ataxic and have diffuse neurological involvement. and they have partial deficits which keep on worsening over time, and patients gradually become bedbound or moribund. And the time course is very variable. It is few weeks, often to few months sometimes. And sometimes it's taken as a stroke when it sometimes presents rather acutely. But you can see these multiple lesions dispersed over time and over space in these patients. Headache, fever are not characteristic, which will rule out other forms of OIs that can happen in these PLHIV. Next. So whenever there is a steady progression of focal deficits having typical features on the MRI, hypodense, non-enhancing, they are non-enhancing white matter lesions. They are hyperintense white on T2 weighted and hypointense dark on T1 weighted MRI images. There is no mass effect, there is no perilesional edema. So that is how you diagnose in a patient who's with clinical features. But if you are able to demonstrate the JC virus by PCR in the CSF sample, it can be done. Normally, we don't do it. It's usually a clinical diagnosis along with a radiological picture, which is supportive of the clinical diagnosis. Next. These are the images that you can see. You can see these white lesions which are there, which are in multiple areas of the brain. So this is classical PML. There is no effective treatment specific for the PML, but the main approach is to preserve immune function. So how do you do that? You do that by giving antiretroviral treatment. As soon as possible, patients who are not on treatment should be started, and especially if PML is recognized. It is very complicated, that sometimes it can present as an iris, that it can worsen once you start, but then it usually settles down after some time. But if patients have very high plasma viral loads, especially CSF viral loads are very high, it has a worse prognosis. And also the lesions that are there in the brainstem, there are multiple lesions, they've been present for a long time. The prognosis is not very good in whom there is very largely established disease. So that is all about PML. Next. In HIV encephalopathy, on an MRI or a CT, you will find atrophy, cortical atrophy, and there may or may not be basal ganglia calcifications. For toxoplasmosis, you will find single or multiple ring enhancing lesions with mass effect. For tuberculomas, there could be single or multiple lesions, but there will be other features, like there could be associated meningitis, there could be associated hydrocephalus. And for PML, there will be multiple hypodense lesions in the white matter. These are white matter lesions, no enhancement, no mass effect, no peripheral edema. So this is how these features can be differentiated by an astute radiologist who looks at these features. Next. Hand HIV associated neurocognitive disorders. Next. It is actually a progressive decline in cognitive functions, or there is cognitive impairment classified as asymptomatic neurocognitive impairment ANI, MND, minor neurocognitive decline, or very severe, where the decline in cognition is very severe. So patient becomes functionally impaired in day-to-day activities and generally is bedbound and has very, very poor prognosis. That is HIV associated dementia. Hand is an important cause of all cause morbidity and long-term ill effects and mortality in these patients. Had HIV-associated dementia is very rarely seen, but mild impairments are quite common. And if you test for these patients with neuropsychiatric tests, you may be able to demonstrate mild dysfunctions, and the treatment is usually with only ART. Next. So here, if you see, there is cortical atrophy. Look at what has happened. The ventricles seem to be bigger. There are no white matter lesions, but there is cortical atrophy. And like I said, ART, especially ART drugs which penetrate the CSF, like zidovudine, like stabudine, like nevirapine, TDF, these have high CSF penetration. So your regimen should preferably contain one or more of these agents. But again, if it has been there for a very long time and patient has severe dementia, then it is not very responsive to many forms of treatment. Next. Bacular myelopathy is very rare. Next. It presents as a spinal cord disease. Patients will have cord involvement in the form of motor tract, in the form of sensory tract, bladder bar function, posterior column. So again, it presents as a cord involvement as a myelopathy, and it's one of the differential diagnoses of any patient who presents with myelopathy. And so you should be able to see the MRI, which will show hyperintense lesions on T2 weighted imaging, again principally in the thoracic lesion, and again no specific treatment, but you should rule out all other causes of cord involvement in these patients. Next. Primary CNS lymphoma, just one word on primary CNS lymphoma. Next. It is an important differential diagnosis to any ring enhancing lesion, always associated with Epstein-Barr virus, usually seen in CD4 count less than 100, and it presents as a focal lesion. Lethargy, confusion, memory loss, focal weakness, seizures, cranial neuropathies, and there will be irregular lesions that's solid and on enhancement. And of course, you may think it is toxoplasma, you may think it is tuberculoma, but when they fail to respond to toxoplasma therapy and it's still there, and patient has features of raised ICT, you should you should think it is primary CNS lymphoma. There is no chemotherapy available for this, and resection has to be done for primary CNS lymphoma. Next. Neuropathies are again very rare phenomenon, but there are many other causes of neuropathy which can happen in patients. Patients can have alcohol, next, alcohol-related neuropathies, drug-related neuropathies, diabetes-related neuropathies, many other, earlier stabudine used to have neuropathy. So there are multiple causes of neuropathies. HIV is one of them. You have to rule out all other causes before you ascribe the neuropathy related to the HIV. And for the neuropathy, there is no particular treatment. It is just conservative management and starting ART for all these patients. Next, I think the last one is neurosyphilis. We will go on to syphilis. It is important next because it has re-emerged in this era of HIV, and it can present in one of the three forms. Either it is asymptomatic, or it presents as an acute syphilitic meningitis within 1-2 years of the primary infection, or it presents later with meningovascular syphilis happening after a few years of the infection. And it, depending upon what stage of syphilis you are thinking, that will be the kind of manifestation it has. Next, the diagnosis is achieved by doing a CSF BDRL. You have to do a CSF BDRL, which has to be reactive. Presence of CSF cells about 10 to 100 and mildly elevated protein. And if you are suspecting syphilis, you will treat with benzathine penicillin 4 million units every 6 hourly for 10 to 14 days. And again, the follow-up depends upon the stage of the neurosyphilis when you are trying to find out what is to be done further and monitor these patients. Next. All right, I think we have done a marathon session on CNS.
Thank you so much, ma'am. Yeah. Any questions from the participants? Kiran sir, can you please unmute the participants now?
Done, ma'am.
Yeah, thank you. Participants can now unmute themselves if they have any questions. Any questions from the participants? Yes, sir.
Give the answers for the.
Yeah, after the post test, sir. Yeah, we'll do that, sir, after the post test. Any questions from the participants? Ma'am, I don't think there are any questions. Can we quickly run the post test, please?
Yes.
Thank you. Kiran sir, can we have the post test? Thank you. The post test questions are now available on your screen. There are 4 questions in all. Please attempt all the 4 questions. Kiran sir, we can end the post-test and take up the feedback form, please. Thank you. The feedback form is now visible on your screen. Please go through the questions. There are 4 questions in all. Please answer all the 4 questions. Regarding the sharing of materials, the PPT along with the recorded link is shared by us via for all the ARTCs. We share it via email. Kiran sir, we can end the feedback poll, please. The answers to the pre and post test. The first question was, when is preemptive antifungal therapy to prevent the development of invasive cryptococcal disease recommended? The answer is when serum CRAG is positive, CSF CRAG is negative, and patient is asymptomatic. Second question, serum CRAG test is recommended in any PLHIV with CD4 counts less than 200 cells per milliliter. Which of the following statements about CMV, that is Cytomegalovirus Retinitis, not true? The answer is CMV should be treated for at least 12 months and regular follow-up should be done. Which of the following statements about toxoplasmosis is false? The statements that is false is serum IgG and IgM anti-toxoplasma antibodies, if present, indicates active disease. The next sessions are on 23rd August, that's Tuesday, and then on 25th August, that's a Thursday. We thank you to all the participants for patiently waiting for the extended period of 15 to 20 minutes. Thank you for attempting the pre-poll and the feedback questions. Thank you to NACO for the opening remarks. Thank you, Anuradha ma'am, for facilitating this session. And thank you to Amit sir also for facilitating this session. Ma'am, can we conclude the session now?
Yes, yes, please.
Thank you so much,
everybody, for your.
Thank you.